Good morning, good afternoon, good evening, Section 3. I hope you guys are doing well. Wow, kind of an interesting last 48 hours. So first off, I want to apologize on behalf of EIM for what's been going on the last, well, now I guess it's been 24. I guess we still haven't gotten the data back, but we're up and running in Moodle. Again, I've been teaching these classes for 5-6 years. I've taught probably 10 sections, maybe 12 or 15 actually, now that I think about it, because I've done more than 2 a year sometimes. And I've never ever had things get lost or not being able to put forth. So I just want to apologize for that, and hopefully they'll get it all rectified. I just wanted to touch base with you guys. It's been a week. I like to keep in contact. I feel like videos are a good way to do that. I'm going to make this relatively quick, but because I didn't really get to everyone as I was planning on doing that, getting over to Charlie and Delta but everything is lost, and whether it comes back or not, I'm not sure. I got to think it will, but by that time we'll probably have moved on. I just want to do this quick case, kind of go through the case subjective questions and information, so that really quickly, just so that we all kind of come together at the end to have a good understanding of what was going on. So first off, the structures involved. One of those questions is I think that's a really important question that we all need to be going through when we're working with people. Great for hypothesis forming. Basically in your mind, running through a differential of what these things can be for this patient is a strong exercise, and I think we need to do it more often. Far too often, I think there are people in our profession who will get a referral, or they'll just hear the patient say, I have this, or this is my problem, and they don't dive deeper, and they don't think in a broader scope. And so by kind of rattling off all the possibilities and really wrapping your brain around all the structures that could be involved, and then doing a systematic process of eliminating those which don't make sense based on that subjective questioning, and trying to hone in on what the exact problem is, I think that's a great exercise to do. Understanding referral patterns. Again, I have pain science education there as another one. We do a great job with pain science education. But sometimes those two things can come in conflict, right? When we don't really know, when sometimes pain is obtuse. Is it that they're under a lot of stress, like this woman who was dealing with a relationship issue? She was dealing with lacking of a support system, a new environment. Is it really that her nervous system is very sensitive and she's just really jazzed up, or based on understanding referral patterns and where she was getting her pain and understanding structures that are involved, what this could possibly be something more sinister? And I do think that that's really good exercise, again, to undergo. And I thought everybody did a really good job of really, covering all that could possibly be involved. Moving on to the red flag screening. Again, thinking about things like unexplainable weight loss of greater than 10 pounds, a recent fever, loss of appetite, lack of sleep, or pain with sleep, the 5 Ds and the 3 Ns. Are we making sure that we're covering our bases so that when something just, that sniff test, it just doesn't sniff or smell correct, and it kind of makes the hair on the back of our neck stand up? These are the kind of things that we're looking for. These are the kind of things that we need to be cautious of, because we're seeing more and more direct access patients, and we need to be the ones who are able to appropriately screen these people. Spot. Oops. My mistake, gang. There we go. Yellow flag screening. The 2 yellow flags, well, for certainly the woman who is struggling with the anxiety, and whether she was depressed or not is not really, it's not even for us to make a call. But a lot of people, not everyone, but a lot of people refer to the PHQ-2 as an opportunity to perhaps open up that discussion. And some of the discussion about whether that's too invasive on the first visit, talking about that, I think is a fair point. However, I would argue that if you use the PHQ-2 as a jumping off point, a lot of times people will they want to know, well, why am I filling out this form? Why are you asking me this, right? And it's a great opportunity to say, well, we know people who have uncontrolled depression struggle with more pain, and this is all we're trying to do. And we really, if you have uncontrolled depression, and we want to help you, we want to get you back to primary care, so we're addressing this. And it opens up the discussion. And sometimes I've certainly had countless times where people have said, yeah, I used to battle depression, but I've got it under control now. Or, boy, I appreciate you telling me that. My mom has it or my dad has it, and I've never been diagnosed, but I do get blue sometimes. And, they may not even score greater than a 3 on the PHQ-2, but it's an opportunity for discussion. The cardiovascular risk is maybe, it floats between red and yellow. I guess it probably could be more of the red, especially if they're coming into your office direct access, complaining of unrelenting neck pain or neck pain that has not been, that has come on suddenly. So there's that aspect of it. But I guess that's the red flag. The yellow flag is, should we be taking blood pressure on any patient that enters our clinic? And, I think there is a lot of evidence that says we should be doing more blood pressures. It's simple, it's easy. And I've thought about how we can implement it into our clinic with our aide, just doing that, taking a blood pressure on everyone who comes into the clinic, because there's a lot of information that can be gleaned from that. And especially, if you're doing manual therapy on the neck, especially if they're direct access, EIM has taken the approach that we anybody with direct onset of neck pain, you should always, manipulate thoracic spine first. There's enough evidence that says that that's effective, and then give it time and see, and making sure that if there's any question or you have any doubt, that you save that for the next visit. Well, again, we have to be understanding cardiovascular risk. For a lot of people, I posted in Dropbox the Roger Carey and Alan Taylor article, and Julie Whitman referred to it in the upper extremity examination as well. It's a great thing to keep in the back of your head, because it really does make a difference. The moving on, relationships between the three. The key, I think, is to try to understand if there is a musculoskeletal component here, right? Is there a tie-in? I just had a woman the other day who came in with neck pain and wrist pain, and she was put in a wrist splint, and I thought perhaps they could be connected. Turns out they weren't. They were two separate issues, but she did say, funny, they came on at the same time. Maybe there is some connection there, but they seem to be two separate issues. But the point is, with that relationship question is, are we starting to tie things together? Can we use, because if we can, thinking about referral patterns, passive radial and median and ulnar nerve, those kinds of things, and bringing those into it. I thought everybody did an excellent job with the SINs, talking about the irritability, the nature, the staging, the stability. I always talk to patients about irritability because it helps them better understand what's okay. And so going through the exercise of understanding these kinds of things is really helpful, because I think it helps give you more confidence. It allows you to talk to the patient. So I'm always wanting to know about these things. Maybe I don't, and I don't do this, obviously I don't do this formally in my brain, but when I think about, of course I'm staging. Of course I'm wanting to know the nature. Of course, because the staging, is this acute, is it chronic? Where are we going with this? Irritability, how hard do we push? How do I tell my patient do I tell them to push harder versus not? And then that kind of leads into the vigor of the examination. A lot of you, we're all over this, like, that shoulder, man, you weren't going to do too much to that thing. I mean, it's just, they're pain, right? When I work with students in PT school, they have this idea that they have to follow up through the entire examination, which means, every special test, which means overpressure on every end range, which means, in reality, there are some people you just hardly can do anything with, because if you do that, it's just going to make them cranky. And that's why, active range to passive range to overpressure is always good. And everybody seemed to really understand that, and that the shoulder was going to be more limited. And sometimes people will say, well, of course, that's what we would do, because I would never do that. But I think it's important to, again, do the process and be clear in your mind, well, what am I going to go after here? What is going to be, and that shoulder may tolerate very little, and you may spend more time from a manual therapy standpoint trying to get that shoulder to calm down by working through the neck, and then going back to the shoulder. But we'll save that for the objective examination and then treatment to follow. The rest of it, everybody had I did not write this down, but the special tests. One of the things that people talked about was listing some special tests. Don't forget about your clustering of special tests. I made mention of some of the different reflexes to be checking. If you look at a lot of people hit the common ones. A lot of people had Hoffman's, which is really good because, I have seen positive Hoffman's on a number of different patients actually with cervical myelopathy. But as you'll learn if you haven't already taken the cervical thoracic course, there's various stages of cervical myelopathy. Not some of it can respond very well to conservative management. I've had the opportunity to work with a couple that have, and with a positive Hoffman's. But that inverted supinator reflex is often something good to check. And you look in the Cook article on the clustering. That's a very solid. And then keeping in mind the clusters, and we're going to get more into special tests in the upcoming blocks because we need to assess the value. But then we'll start to talk about clustering of those special tests, such as Hawkins-Kennedy, NIRS, and those, and finding where the value really lies. Okay, so I'll stop rambling. That everybody did a pretty solid job from what I saw. Hopefully we get that information back, but we're going to be moving on anyways because we've got to get to our readings from this week into week 4. And then just an FYI, well, I'll save that for next time. You guys have a great day. And any questions, shoot me emails. Hope you all are well and enjoying this information. Enjoying getting to know you and getting to see how people think. Take good care. Bye-bye.